Hello and welcome. Isn't it good to be back? I think I last stood in this hall in October 2019, 3 years ago, at the last face-to-face Health and Care Research Wales annual conference. And I think it's lovely to see people back in this room after 3 years and 2 virtual conferences. I'm Kieran, Walshe, Director of Health and Care Research Wales. And I think it may be because it's such a wonderful conference, or it may be that people have just really missed the opportunities to talk face-to-face, to have snacks and muffins, to be in the same room and all of that kind of stuff. But over 400 people registered here in the room for today's conference, and 100 people joining us online. So welcome to the people who are joining online. We'll say a bit more about that later on. Lots of people joining from offices and living rooms and so on, but also a particular welcome to groups who are joining in Bangor and Wrexham, so joining our plenary sessions virtually. Let's look back for a moment at the last couple of years. It has been a bit of a wild ride, really, for research, an extraordinary period in which research has been front and centre in everybody's minds and has mattered more than ever before. And our tagline of, where would we be without research, it has a certain, real relevance to the way in which the pandemic unfolded and the extraordinary response from this community and research communities right across the UK and across the globe to the challenges of the pandemic. But we've also carried on doing other stuff. The normal business of research has remarkably continued over this really challenging period. In Health and Care Research Wales, we've continued working on funding calls, funding projects. We've continued with initiatives like the One Wales work around research delivery, our PPI work, which is an area in which we lead in the UK, our Discover Your Own campaign around engagement, and of course, that where would we be without research awareness raising campaign, which, as I said, has a real traction given our experiences for the last couple of years. You will find all of that laid out in lots of detail in our annual report, which is published today online. It's on the Health and Care Research Wales website, and there's a clever little QR code in your programme that you can point your camera at on your smartphone, and it will download the report for you. So please do read it, and really importantly, share it with other people. Share it with people in your research teams, but also with people in health boards and trusts and social care organisations to get that message out. But this is also about looking forward and thinking about what's next. So what should we be doing over the next few years? And we've been working on our plan for Health and Care Research Wales for 22 to 2025. And we'll be publishing that in the next week or so in draft form on our website. And we very much want comments and views from the community about what it says. The sort of, the spoiler alert is we think there's a lot to do. There's a lot to do in the health and care research space. There's a lot that perhaps has been delayed by the pandemic. And over the last few months, there have been a whole series of initiatives at a UK level, as well as in Wales, but particularly at a UK level, around clinical research delivery, around the UK life sciences vision, new strategies from UK research and innovation, lots of developments in the arguments for spending more money on science, lots of developments around levelling up and the place agenda. There's a great deal for us to get a grip of. When you have a look at our draft plan, you'll see it's organised around what we see as the 4 main aims for health and care research, which are setting the agenda for health and care research, driving strategy, encouraging all organisations to have or be part of a research and innovation strategy and plan. Secondly, planning and organising health and care research. That means working on the funding that we provide, but also working with other funders, with NIHR, whose programmes we buy into, with the MRC and the ESRC, with charity funders and others to get the research that needs to be done, funded and supported. A really big theme in the plan is capacity and capability, building capacity and capability in the health and social care system to lead research, to do research and to deliver research. And that's about health and care organisations, but also about our higher education institutions. And the 4th theme is using research, doing things that will make a difference, that is visible to patients and people and populations, seeing research used in practice to improve health and care services. Some of what you'll see in the plan will be familiar, I think. People will know, I hope you'll know, about the launch of the Health and Care Research Wales faculty to bring together our work on providing personal awards and career awards and supporting research careers, but also to work with other funders in that space. The work we've done with the COVID-19 Evidence Centre, which is being mainstreamed as an evidence centre to support decision makers in the health and care system and in Welsh Government. A recent initiative to put resource into funding a new centre for adult social care research, and lots more. So that will be on our website in a week or so, and we really encourage you to have a read. We are reconvening the Health and Care Research Wales Advisory Board, which had fallen somewhat into abeyance, chaired by Sir Frank Atherton, who's here this afternoon. He's giving the first address in the afternoon session. Our Chief Medical Officer, and that will meet, we hope, by the end of this year or early in next year to take the plan forward. So, exciting times. I now swap to the boring housekeeping stuff that is, part of every conference chair's role. Firstly, do tweet about what's going on in the room. The hashtag's been, it's there, it's up on the screen, Research Wales 22. Do tweet nice things, obviously, about what's going on in the room. Do visit all the stands. You've got, I think, a token that you got at registration, and there's a voting system. Don't ask me quite how it works, but to vote for the best stand. We will be having a number of awards given by Judith Paget at the end of the conference, one of which will be for the best stand. So we do encourage you to vote, but more importantly, actually, to go around all the stands and visit, because people have put so much effort into putting those stands together, and it's your job to go and use them and make the most of them. For those who are online, you're really welcome. Your input into the plenary sessions is via Vimeo, and there's a Vimeo function for contributing to the chat and putting in questions and answers, and by the magic of technology, those will appear on this tablet in front of me, I'm told. And so we want you to do that, and I'll be in this, for example, this first session, feeding your questions and your contributions into the discussion. There's no fire alarm today, so if the fire alarm goes off, you need to leave the building, which I think you'd probably do even if I hadn't told you to do it. And you've got the programme. There are workshops, some of which in here, some of which are in the Amber Lounge, but there are stewards at the back to direct you to the right place. So that's all I'm going to say by way of introduction. We started a little bit late, but we'll probably try and catch up some of that time. So we're going to move into our first sessions. We're going to invite our contributors to come up and join me in what looks a bit like the Sky TV studio here, in our seats. I think we're still missing Brendan Healy, aren't we? So, yeah, we are missing Brendan Healy. That's okay. So, moving into our first session. This first plenary, we wanted to have a plenary that kind of did two things, that both celebrated some of what has been achieved in research, both around COVID, but also in areas other than COVID over the last couple of years, but also encouraged us to reflect on what we learned from that experience. And we wanted to pick out some areas where we thought there were great stories, narratives of research impact, but also kind of opportunities for us to learn from how those research impacts have happened. And so I'm delighted to welcome Diane Seddon from Bangor University, Reader in Social Care, Adrian Edwards, who from Cardiff University, Professor of General Practice, directs the COVID-19 Evidence Centre and also Prime. Andy Sewell, also from Cardiff University, Distinguished Reverse Professional Wellcome Trust Senior Investigator. I was hoping to welcome Brendan Healy. He's this sort of chair at the end, who's a consultant in microbiology and infectious diseases at Public Health Wales. So we're hoping he's going to make it, but if he doesn't, he doesn't. And last but far from least, Martin Rolph, who's a long-standing contributor to patient and public involvement in health and care research in Wales. We wanted the format not to be a whole load of presentations. We wanted to make it more interactive than that. So we've had an earlier discussion, and what I'm going to do is hand over to each of our contributors in turn to introduce an area where there's a kind of story about research and research impact. They're going to introduce it for a few minutes, and then we're going to draw in our panel members to contribute and comment, and also comments from people at home. If you want to make a point, we have got 2 roving mics. If you want to make a point about any of that, you can stick your hand up at any point, but we'll try and keep a bit of time at the end to draw in plenary contributions from the hall. So that's the format. I'm going to go first to Adrian Edwards, who's going to talk about long COVID research. And I'm going, since Brendan's not here, I'll go and sit in his seat, and we'll see how it goes. Adrian, over to you.
Welcome back, Kieran. Good morning, everybody. Can you hear me all right? Great, thank you. So the example I thought I would bring to you for a few comments, and we look forward to questions and discussion after, was about long COVID. I think there are some challenges and some opportunities that have been encountered during these last couple of years in relation to that, which I think could be quite informative for us. As everyone knows, long COVID is clearly a massive problem. The significant impact on individuals and the numbers of people affected, the estimates are probably anything up to around 2 million people affected in the UK, and across different waves of the pandemic up to now. So clearly a substantial response was required for research by funders and of course the researchers, and I believe personally on the whole that has been achieved and implemented. I accept the point of view from people who might think that more could and should have been done. Absolutely, fair enough. But I think there are at least some significant positives that we can pick out of it, including the mainstream NIHR funding and more. So NIHR rapidly called for and funded first 4 research projects and then 15 more in 2020 and 21. And for a total of £39 million across those 19 studies. And there's around about another £10 million of funding from other funders as well. So I think the first point, just to bring up, I think, is the rapidity of recognizing the issue and identifying the funds and commissioning the research, and of course the researchers and their universities gearing up and getting going in double quick time. So that agility and capability, I think, is something we really want to recognize and work out how we can take that forward over the next few years. The second point I just want to mention is about the type of research that was commissioned across that program, and in particular how varied it was. It started with epidemiological studies of both adults and children, and then moved into a number of evaluations of both interventions and services. So those evaluations themselves were very mixed. Some were straightforward RCTs, including via the Heal COVID platform, so thinking about therapeutic trials, but then also behavioural and supportive interventions being trialled, including the LISTEN study led by Monica Bousset in Cardiff here. So a number of evaluations were going on by trials, but also some observational levels of evidence, I think, is really important to acknowledge. So one example is the locomotion study led from Leeds, which is evaluating 10 routine services across the UK, one of which is in Wales. So they've used routinely collected data as a means to evaluate cost effectiveness of the services. And there's also a literature review, which is digging into and understanding the pathophysiology of long COVID and how we can understand that, the mechanisms of this somewhat arcane condition, and learning about, I think it is really groundbreaking research that they're doing, learning about the inflammatory processes and the clotting cascades and amyloid protein and so on, that then feeds through into the pathways that will ultimately lead us to experience anxiety, depression, fatigue, and the other physical manifestations. So I think there's really strong research there. My point really is about the value of different levels of evidence. So sometimes, yes, RCTs, sometimes also observational levels of evidence will still be very, very informative. And I think we also saw that, for example, with the evidence about mask wearing a couple of years back. So I think that's also something I'd like to see us make sure we keep hold of and take forward for the next 2 to 5 years, whatever we're looking at. The third point, just to mention, final point, that out of this rapid dedicated research program, I think we can start to see there might be a slight risk of going back to what we might call the bad old days of research processes. 1 or 2 nods in the audience about the time and complexity that it took to get research started. So, for example, I'm thinking about the approvals required for using the routine or anonymized data sets. it did become very nimble and agile during the pandemic. But what I see with one or two of these long COVID studies is maybe it's getting increasingly difficult again to get approvals from the confidentiality advisory group and NHS Digital and the like. So I think our colleagues here in Data Health and Care Research Wales and Sewell Data Bank and so on are in a slightly better position, but I think there might be some issues there for us to think about not completely going back to the way we did it before, as we might see in some situations in England. One other comment, public and patient involvement. I think it was very strong. Was it eroded a little bit during the urgency of research that happened? And maybe we want to think about getting back to the strength of the public and patient involvement that we had and know how to do really well, and to make sure that it is essential and integral in the research that we do. So just a few things have changed, and we want to think about how we do and regulate research and make sure that we keep what went well and overcome what might be slipping back a little bit. Thank you.
Many thanks, Eric. There's spontaneous round of applause. Is my mic working? Yes, it is. Loads to pick up on there. I wanted to pick up, and perhaps with Martin, the PPI aspects of this. People have, I think everyone knows that there is a long COVID patient community that has come together over the last 2 years and has been very active in sort of challenging the service sector to say, where are the services for these people who have a chronic disease we don't understand, and challenging the research community to do something about. And people have drawn parallels with the chronic fatigue syndrome community and its response, and also much longer ago, AIDS and HIV, and the challenge, if you like, from the public community and particularly from patients to the service to do the research that is needed. There's been a degree of active engagement right from when I think Elaine Maxwell and NICE published their initial work around what is long COVID, what's the phenotype of long COVID. And that's quite challenging when the research community hasn't even really understood what the questions are about long COVID, and the understanding of the underlying physiology of long COVID has been really complicated and difficult and not well understood. Martin, any reflections on how we engage with what is an active and, to be frank, angry patient community?
Not directly, because what I would want to say is that the hundreds and hundreds of people now in Wales who are active in PPI, in health and social care research, are incredibly varied, as are their motivations. And I personally have never been motivated by personal conditions, so I'm one of the worst people that you could actually ask that. What I would say, and I was very interested in what Adrian said about the world beyond long COVID and COVID generally, is I don't think there's anywhere, and I agree with what he said about the leading nature of Wales in relation to PPI, but that's no grounds for complacency. What I think is there needs to be a lot more involvement of the public and people giving more time in PPI and general investment from other stakeholders into prioritization exercises, because I think one of the faults of the system and the way things get funded is that there isn't enough attention given to prioritization and to the role of PPI in that. But it's PPI, or the second thing I'd say is that I think that whatever the shortcomings that Adrian would say, PPI can happen very fast. Researchers should not assume that you can't get responses within hours, sometimes certainly within days, and particularly if you have a group of people, they don't all have to reply if they're not able to. You'll still get something useful out of it. And what you were saying about, what are the questions? Well, I think one of the things which is probably better understood in Wales, but still not as widely as it should, is that PPI and the public more widely can play a part in helping researchers formulate the question from the very word go. And very often, some of those projects suffer because they only really beef up their PPI when they're told to by the funders, and there's too much tick box just for the funders. I think it's getting better, but if you're going to have to do something, you might as well get it to add as much value as possible to the output.
That's a really interesting point. And the James Lind Alliance experience
Yes.
in this is very relevant, because study after study, they've seen that if you ask patients and service users what are the research priorities, and if you ask clinicians what are the research priorities, and you ask researchers what are the research priorities, you get different answers. And that doesn't mean any of them are necessarily invalid, but it just means if you have a process for priority setting that just listens to the research community, which is, to be honest, tends to be the strongest voice, you get a particular set of answers. I think it's to be honest, I think it's great that there's a really active long COVID patient community that's challenging the researchers and the service users, because there are unsolved service questions about should you have separate services for long COVID? Should long COVID treatment be mainstreamed inside services for existing patient groups? So loads of answers. Anyone want to come in?
Could I ask a
Go on.
question? Going forward, to what extent do you see the new national standards for public involvement actually supporting?
Could people hear that question? No, I
can't
think
hear
your
me.
mic is now on. Say it again,
Okay, I
Diane.
was going to say, going forward, could you say something about the new the national standards for public involvement in research and how they may help us to support people with long COVID?
I think that's for you, Martin.
Well, I'd like Kieran to say a bit, because HCRW's logo is on the cover. I think written documents and policies are necessary but not sufficient, because it's the spirit that matters. So I think it's a starting point, and all serious researchers and funders should look at what's in the 4 countries, because I think they're all owned together, standards. But a lot of them are sort of common sense and so on. So I have to say, I have looked at them in the past. It's quite some while since I did look at them. It mustn't become bureaucratic, though. You've got to be careful with standards, because you can, it's the old Russian tractor thing. You can meet all the targets, but then fail to produce a tractor. And, it's getting the balance right, I think, is important. And so we've got to have it, but it's not the be-all and end-all.
I think you have to want to do it, actually. And a personal anecdote, a research project I'm involved in at the moment, looking at locum doctors. We have a very active patient group, and they've been involved in running the focus groups with patients. And if we hadn't done that, I don't think we'd have realised that patients' experiences of locums, one of the things they've said is, actually, I quite liked seeing a locum because it gave a fresh pair of eyes on my condition. And I've been going to see my GP, it's not just GPs, but I've been going to see my GP with this issue, and then I saw a locum, and they said, oh. And I don't think any of the clinicians we've interviewed for this study would have told us that fresh pair of eyes idea, but it came out really strongly from the patient focus groups.
I'd certainly agree with that. And one of the biggest problems, I think, because I've been involved a bit with primary care, and particularly in certain groups which have GPs on them, is that it's a critical role of GPs to be an advocate for the patient, but they're not a substitute for patients in R&D PPI.
Yeah. I'm going to move us on to the second example. If Brendan doesn't arrive, apart from publicly shaming him, as I have done a couple of times now, if Brendan doesn't arrive, he was going to talk about the recovery trial, and I might try to introduce that myself from my own knowledge, because I just think it's such an interesting example of a new approach to doing research, and there's a lot to learn from. Diane, can we turn to you for your example?
Okay, thank you. Good morning. So the COVID pandemic shone an uncompromising light on the health and social care workforce, their pay, their conditions and their well-being. And it also showed the health and social care workforce at its best. So health and care workers have responded with dedication and skill. There is recognition of staff as key workers. The workforce has rapidly developed new ways of working, and we've seen the NHS, local government and other providers come together like never before to coordinate their responses to support their local communities. So against that backdrop, I'd like to showcase the Health and Social Care Workforce Study, examining the impact of providing health and social care during the COVID pandemic on the UK health and social care workforce. So this is collaborative work that's led by Ulster University in collaboration with Queen's University Belfast, Bath Spa and King's College London. And I think it's a really excellent example of researchers and funding organisations responding rapidly to try to understand the impacts of COVID, to disseminate findings at pace and at scale, to mobilise knowledge and to try to develop timely recommendations to shape practice. So the research involves over 11,000 members of the health and social care workforce, including nurses, allied health professionals, social care workers and social workers across a wide range of settings. And it documents the challenges these workers face in caring for people with often very complex health and social care needs, whilst also putting their own health and potentially their own lives at risk. And the research findings have been reported in real time, and it's charting their experiences over a five-year period, starting with the first survey in the first wave of the COVID pandemic, and there have been subsequent 4 surveys and focus group work with both frontline staff, managers, regulators and professional bodies. And the studies focused on the mental well-being and quality of working life of the sector. So why is this work important? Well, I think the research, first of all, provides the health and social care workforce with a voice that evidences the impact of working during the pandemic. And this workforce, this workforce intelligence has provided data for employers, policymakers, regulators and professional bodies to better understand the well-being, coping mechanisms and work-related quality of life. And the findings are now informing recommendations for employers and managers in terms of how to best support the workforce as we move out of the pandemic, and also crucially how to prepare staff for possible future pandemics and epidemics. So the research has identified the sustained support needed to help staff across 3 systems levels, so at individual, organisation and policy level. So examples of policy recommendations arising from this research include the coverage of statutory sick pay, which is now being reviewed. Okay. Examples of organisational level recommendations relate to putting into practice the advantages of more flexible employment so that employees feel that their needs and their circumstances are being recognised. And examples of individual recommendations relate to enhancing counselling, mentoring and coaching supports to enable staff to manage the aftermath and the emotional legacy of the pandemic. And I think a really important finding from this research is the way that the workforce has moved away from positive ways of coping to more negative ways of coping, including self-blame and in some instances substance misuse. This evidence is helping the sector to identify forms of support to address these issues before they become embedded, including targeted interventions, psychosocial education and training. And it's also informing discussions about whether stress and coping training should be mandatory for some professions. This research also spans all 4 areas of the UK, and I think the pandemic has shown that there are differences in the way that the 4 nations actually approach health and social care. So, for example, proposals for a new national care service in both Scotland and also in Wales. And so as policies diverge, I think that studies like this become even more important so that we can understand the impact of these distinct policy directions on the experiences both of the workforce but also the people who engage with health and social care services. So in summary, I think this study is an excellent example of research collaborations delivering impactful research with real-world impact. And we can see evidence that policymakers and practitioners are actively utilising the findings to bring about positive change and to improve workforce well-being.
Many thanks, Dan. I think that's a really interesting example that you put forward. And I'll open up to other people to comment, but just a personal anecdote. I was talking to a care home manager last week who manages a small sort of 23-bedded care home. And COVID came up in the discussion, and I thought she was going to burst into tears. 2 years later, you know, and she talked about 5 residents who had died during the sort of 2020 period, and their experience of feeling they were just completely on their own. It was a sector that was kind of pretty broken before the pandemic, and it's still broken. And the Health Foundation published startling analysis yesterday or the day before on pay rates for workers in social care, showing that a huge proportion of people who work in social care are basically living in poverty. It's such a huge problem, and I think it's great to have research that tells us the huge problem is huge. What's really hard is to work out what we do about it, because the policy response has been so inadequate for years. I mean, we've published white paper after white paper after white paper. You're quite right, there are some really interesting differences in Scotland and Wales, but fascinating research. Comments? Anyone want to come in? Adrian, do you want to come in on
Sorry, I missed the content, but I think about the impact on health and particularly social care workers. So, as many people know, we did a review in the COVID Evidence Centre about the impact during the pandemic on key workers for mental health. And one of the next steps that we want to do actually is to set up essentially a cohort of key workers, health and social care, that we can actually track mental health impacts longitudinally and identify, you know, what is the scale of the impact and then what needs to be done for it.
Martin, anything you want to come in on?
Well, nothing except to say that as health and social care together are such huge employers across Wales, and when you add in people close to them, the relatives and others, you're talking about the health and well-being of a significant chunk of the whole population.
Yeah. And again, there was some analysis, I think it was the IFS this week, on the workforce, saying that something like 1.8 million people work in social care, and there are 165,000 vacancies, the highest rate of vacancies that there has ever been. And that connects back to the long COVID question, because what long COVID seems to have done is take people out of the active workforce. And again, there was some great ONS analysis this week showing how many people have exited the workforce pre-retirement, but they're not seeking employment, and the numbers who have disability have gone up. And that's the long COVID economic
Could I make a shout out for unpaid carers, because they're affected too, and that's not an area that should be neglected either, and that's been even more neglected over the years by policy.
Absolutely. I'm going to move us on to our third example, and we're switching away from COVID, I think, almost completely. Andy, over to you.
I think you're switching to a completely different example here. So my research is far more at the sort of lab bench, you know, molecular end of things, and so we've got a good spectrum up here, I think. And I'm glad to hear my microphone's on. So although we did work on COVID during the pandemic, and we just had a paper out in Cell, I think last month, showing that it escaped from T cells, this seems to be very COVID-oriented, the panel. So I was going to talk about an example that wasn't COVID. And Mairead Evans was almost in the front row. But she'll be very pleased to hear the example I was going to talk about was actually cancer immunotherapy, which is obviously the kind of thumbs up from Mairead, thanks Mairead, which is the latest example, really the newest thing in the last. Cancer therapy hasn't changed in 50 years, really. Still do the same things until immunotherapy came along. And this is really using our immune system to treat cancer. And the key immune cells that allow us to do this are called T cells, which is something I've worked on for many years. And the main job of a T cell is to patrol our body and tell what's self, so what's us, and what's not us, and actually to spot anything that's not us, like a pathogen and potentially dangerous. And then they launch an attack on that. And of course, the classic recent example would be the SARS-CoV-2 virus. So when that virus is sat inside one of your body cells, the only thing in your body that can see it's there is a T cell. It's actually a killer T cell, because they've got this sort of superpower X-ray vision where they can look inside other cells. And if they see something like a virus inside a cell, they then destroy that cell and all its contents. So they're a very blunt weapon, but they're very effective, and they've been essential as part of COVID vaccination. Now, increasingly what we're realizing is that T cells can also see cancer cells. so they can see them and destroy those. And I think this is what's happened in these cases that we're all aware of people who miraculously, certainly in the past when they weren't even treated, recovered from end-stage cancers. That's probably their T cells doing that. We're now doing this through immunotherapy in various different ways through the NHS, but the key thing that we're missing in all of this is when it works, so we get some complete remissions of patients, so in effect cures, some patients for some cancers. We don't know how it works. We know it's the T cells, but we don't know what the T cells were actually seeing. How are they telling the difference between a healthy cell and a cancer cell? So stuff that we've developed during the pandemic and really refined now allows us to take these T cells from these miraculously cured patients to the dominant ones that see their cancer and actually work out what is it that you're actually recognizing. So we've been doing that, and in many cases this has really surprised us. So it's not published research yet, but hopefully early next year. So it looks like what we're doing at the moment in terms of a lot of our immunotherapies is sort of banging square pegs into round hole. We're thinking, oh, this should work, and just trying it. We're taking a different approach here in Wales where we're kind of looking at, well, what has actually worked? And now we want to replicate that in other patients with other cancers. One of the ways we can do this is to actually engineer the patient's own T cells. Now, this is done in Wales, here in Cardiff certainly, on the NHS for certain forms of leukemia, where we take molecules called receptors and put them on the surface of T cells, and these receptors then bind to the cancer. And this, the classic example there is something called CAR T therapy, which is now used as a salvage treatment on the NHS for certain forms of leukemia, and it works. So we now want to extend that approach out to other cancers. And what we can do is we can take the receptors off successful T cells from those patients that have actually cleared their cancers and genetically engineer them into other patient cells and then put those cells back into the patients. I think this will come in the next sort of 5 or 10 years, but the problem with that kind of approach is it's really expensive. It's quite involved and it costs a lot of money. So CAR T therapy is costing sort of £400,000 per patient. So, although it works, it's an awful lot of money. Now, we know through bringing everything back to the pandemic that we can induce specific T cells, for instance, to the SARS-CoV-2 virus. So if we now know what we need to help us clear cancer, then what my long-term aim, and this is a very long-term aim, is to actually vaccinate. So initially you would vaccinate to induce these types of T cells in people that we know that work. First off, you do it therapeutically, but in a far-off distance, I can actually see, hopefully, the possibility of actually doing this prophylactically. So to prevent disease, a bit like we do with SARS-CoV-2 vaccination. So our big problem at the moment is when these things work, we don't understand how they work. Our research here in Wales is picking apart how they work and learning that. And then I think from that, what we now want to do is sort of apply that knowledge back to the patients. So this has really been from patient to bench and then back to patients in terms of the whole research sphere. Over.
It's right. This is a very different example, but I think there's loads of connections with the COVID initiative. And if people have read the UK Life Sciences Vision, which the Office for Life Sciences, which is a UK/England body, has published last year and is now working on delivery, it identifies 6 mission areas. Actually, I think there might now be 7 mission areas, and it's modelled, I think, very much on the experience of the Vaccines Task Force. So policymakers and politicians actually looked at the Vaccines Task Force and said that achieved vaccines for COVID-19 in a timescale that nobody believed it could be done at the start. Why was that possible? And they think it's about research acceleration, but also about mission-oriented funding and about not just dealing with the research, but dealing with the manufacturing and the production and the commercialization all in one place. So Kate Bingham, who led that effort and has published a book, again, it's only come out this week, about her experiences, which from the interviews she's done, it's a fairly forthright read. But Kate Bingham, I think, would argue that her ability to draw all of that together and also to have the degree of access she had allowed them to do that. And so that idea of mission-oriented research is now very popular in government circles, and that's what's driven this. And one of the mission areas is cancer immunotherapy or cancer vaccines, isn't it? And I know Mererid and Alan Gallimore and others have been going to meetings at a UK level to try and work out what that mission is going to deliver. But I wonder, I mean, I'm not going to give you an opportunity to complain about funders and so on, Andy, but I might be doing in saying, you know, do you think the system is organised to deliver that sort of research quickly? Or do you think there are lots of what traditionally we call translational gaps, which mean that it's really hard to get it, as you said, from bench and lab to bedside and into patients, and also then into service delivery? I might come back to CAR-T as well as an example.
Well, there are lots of gaps, but I would say the recent example of what we've achieved through COVID vaccination should really set the stage for what we could do in other forms of vaccination or wider healthcare in general. You know, when everybody rows together and pulls as a team, it's remarkable what can be achieved. So I'm hopeful of the future, and at least they've spotted this kind of thing. And I'd have to say, from my own point of view, money isn't the problem. You know, I can get a lot of money. I'm turning money away all the time. Money's not the problem. My problem is expertise. You know, people that can actually do this stuff, because they are now getting mopped up by all the companies that have spawned out, because this is a very lucrative area. So I just train people for the UK biotech and pharma industry, it seems, and they're just, So that's my big issue isn't money, it's people.
Getting people and keeping people in.
Certainly keeping people in Cardiff, good people, is certainly proving to be difficult.
Yeah. CAR-T, you said it costs about £400,000. You said it works. It works for some patients, doesn't it? Some patients have pretty dreadful immune reactions. It doesn't work for everybody.
It is not the panacea that people hoped it would be to begin with, but I think the key there is it works in some patients. And that's a good thing, and what can we learn from that to actually make it better? That there are some toxicities, you're right, and then the other thing is, because you're targeting a molecule on these B-cell leukemias that's on B cells, and cancers are very good at just escaping, just like viruses, so they lose that molecule. So that's the other issue you have. So this is the big problem across, whether it be viruses, cancer, or whatever, with monotherapies. Really, you want to attack things in several different ways, so that if it escapes from one, it still gets killed.
It's a kind of arms race playing out, isn't it?
Well, there's a lot, certainly the immune system, all the analogies are warfare, as you can imagine, and you can overplay your little, your killer T cells being the assassins, your CD4 T cells are the generals, and you've got all of that. You can pretty much, T-Regs, they're the military police. So you can sort of assign all of that, and it is very much like warfare, and it is an arms race. I mean, as good pathogens beat our immune system, otherwise they wouldn't exist.
And that is what we've seen with COVID-19, haven't we? And it's interesting, I don't think people at the beginning of the pandemic, there was all that stuff about could we just shield people, let it go through the population, and then it's over. But it wasn't over because we developed therapeutics, we developed vaccines, and then the virus responds.
It won't be over. I mean, I think this is probably the 5th coronavirus pandemic in the last 400 years. I mean, we have them endemically. They're what cause 40% of colds and such like. And SARS-CoV-2 will just become another one of those. But then there'll be the next thing, They keep coming. Sorry.
Adrian, Diane and Martin, would you like to come in on this example at all?
I was interested from your comments there. I mean, you're saying what we learned from the COVID vaccination, how that might be translated to essentially cancer vaccination and prevention. But I guess we also discovered a few curious things about COVID vaccination in that it didn't really prevent illness. It prevented hospitalization. Can you comment on that? How do we sort of unpick that?
On a wider note, I would say that all successful viruses have strategies to escape the mammalian immune system, or they just wouldn't exist. And in broad part, maybe COVID's got something we don't yet understand, but I always overlay these in viruses on the key ones, so you can run. The road runner is HIV. is different every day. It just changes all the time. You can hide. That would be Epstein-Barr virus, which kind of goes into a sort of state where it stops expressing its proteins and hides and waits for you maybe to become immunocompromised and then comes back. Or you can fight. And the fighters you learn a lot from, and the classic fighter is cytomegalovirus, which is a huge genome and more than 60 genes specifically designed to fight the mammalian immune system. So I think as a wider answer, they all have strategies. We haven't completely worked out what the strategy is for SARS-CoV-2. Certainly early in a pandemic, the strategy is to run because it mutates and the virus is different. But I just wonder whether there's other things in there, because bear in mind the other coronaviruses we've had for hundreds of years, and we get them time and time again. Every 2 or 3 years you get them again. You would have thought the immune system wouldn't allow that to happen, so they've got something going on where they're kind of subverting the immune system, as do all successful viruses. Hopefully that answers the question.
And there's an interesting link there, isn't there? Because the research on long COVID shows that people who have long COVID are more likely to have an infection with Epstein-Barr.
Right. Well, then, yeah, I won't even go there.
I think what we're all learning is the immune system's a bit complicated.
Well, one of the things about one of my main things in T cells is that they're cross-reactive. We have to cover all possibilities. From the day we're born, we don't know what we're going to get hit with, and we successfully, amazingly, cover all possibilities. But the way we do that is any one cell is covering multiple different bases, as it were, in effect, is what's going on there. And then you get this crosstalk between things where, X can cause Y and all of those. For instance, autoimmune disease, your T cells that might attack a pathogen then attack self. And that's really how autoimmune disease is triggered. But even between pathogens, there can be stuff going on. But I don't want to get too technical here and lose my audience.
I'm going to give Martin the last word on this example. Martin.
Well, it was a different point, really. It's all very exciting and very much obviously to be supported. But as we go forward with this sort of stuff, I think, you sort of say the title is, where would we be without research? I think we need a variety of research, some of it linked to this, but separate, because as was described, the commercial drive to do this is so the interests of companies will come into this in a big way. And I think as COVID showed, there's a big job to be done on transparency and demythologizing, and on equality, because I think it's sort of in worst case scenario, some of the products of this could just go to the more wealthy, and also you could have some of the nonsense that we had over COVID developing. I'm not saying you need to put a lot of money in it, but I think those who are focused on doing what Andy does, I wonder if they can really at the same time be looking about how this down the line when it comes to implementation actually interacts with the public. And the public, not just in terms of compliance with what the health bodies would want, and I think Public Health Wales and the equivalents elsewhere need to learn lessons on that, but also what the sort of public support is for it as well. Because as was said, the companies will put money into this anyway, but sometimes the public purse needs to pick up some of the stuff that looks more towards equality, and that I think equality and diversity are some of the issues that can be helped by effective research.
I think that's a really interesting point, and a lesson from the COVID-19 vaccine experience was Kate Bingham and the Vaccine Task Force were great at the science and the delivery, but we probably didn't do as good a job as we should have done of taking the public with us. So we ended up with a lot of vaccine skepticism, a lot of conflicting narrative, a lot of confusion. I mean, for example, around vaccination of pregnant women. And looking back, could that have been done differently? Probably, but it was an emergency. But for the future, we should learn from that COVID experience. Brendan's not coming, you won't be surprised to hear, at 10:30. We're going to break shortly, but I did want to just say a little bit about Brendan's example. So Brendan led in Wales for the recovery trial, which was the huge trial led from Oxford University, set up to test potential therapeutics. So it was the trial that recruited 55,000 patients, initially in the UK, but then internationally. And it was the trial into which a whole series of potential therapeutic agents for treating COVID were put. And it produced the groundbreaking findings, like that a cheap steroid, dexamethasone, had a really important impact on mortality for patients who were hospitalised and those who were in intensive care with COVID. There was a lovely blog, which I can't give you the reference for, but if you Google it, the LSE runs an impact blog on health, and there was a blog in there about research waste last week, and it said, look at therapeutics in COVID-19. The UK ran the platform trial, 55,000 patients. If you look at other countries, particularly the US, there were hundreds of small, underpowered trials led by individual investigators on things like ivermectin and a whole bunch of other therapeutics, which were a complete waste of money and a waste of the effort and time of clinicians and researchers and funders. So there's a real lesson from the recovery trial about the organisation of research. They were extraordinary times, but that trial was very centrally directed. It was opened entirely across the NHS in the UK. It was the model, in a sense, of what you might argue the NHS should be able to do. You know, large-scale trials with a very large patient population and a national health service. What they can't do in the US can do better in some European countries. The other thing that I think was really interesting about it was the idea of a platform trial, which traditionally we have trials that, you know, have different arms, this against this or placebo against this. And this was a trial where from the outset the intention was to be able to add new therapeutics as ideas came along from the process that had been set up to kind of filter and triage potential ideas. Those ideas from the phase 2 platform went into the phase 3 platform recovery trial and opened a new arm. And that, I don't know, had it been done before? Certainly, I don't think it had ever been done before on that scale. So Brendan, were he here, was going to say, you know, the recovery trial probably changes our thinking about the way we should organise trials and moves us towards a more collective and directed approach to trials, where using platform trials might be really useful in other disease settings, I think. I don't know if anyone wants to come in on any of that. No, I'll let you off, don't worry. We haven't given you much opportunity to ask questions. There will be opportunities in the workshops and so on. And we have not had much by way of questions through from our colleagues joining virtually. So all I'm going to say is, firstly, I'm going to ask you to give a clap in a moment to our colleagues for contributing. But before that, I was just going to say, you've got 20 minutes off now. Well, 17 minutes off to go and get a coffee and so on in the lounge. And then we've got 2 more sessions starting at 10:50. So in the main hall, we have a session that Monica Bussey is going to lead, the director of our Health and Career Research Wales faculty, on building research capacity and developing researchers. And in the Amber Lounge, we have a session on improving public involvement in health and social care research with a panel that's chaired by Peter Gee from Health and Care Research Wales. That's in the Amber Lounge. And if you don't know where the Amber Lounge is, then the stewards can direct you. So I hope you've enjoyed this opening session and the fairly conversational style we've adopted. Enjoy the rest of the conference. See you throughout the day and back at the end of the day when we have some awards and so on with Judith Paget. But please do thank our panel.